My name is Sarah, and I've been working as a senior nurse in the emergency room for over 15 years. In all that time, I've seen doctors come and go, residents who think they know everything, and attending physicians who've forgotten what it's like to actually care for patients. But nothing, and I mean nothing, prepared me for what happened with Dr. Evans Jr., and the day I diagnosed his mother's stroke before his precious MRI team could even get their equipment warmed up. This is a story about respect, experience, and the most satisfying moment of professional revenge I've ever witnessed in my entire career. It all started 6 months ago when Dr. Evans Jr. joined our emergency department as a third-year resident. From day one, this guy had an attitude problem that could be seen from space. He was the son of Dr. Marcus Evans, a famous cardiac surgeon who basically built half the hospital's reputation, and Jr. made sure everyone knew it. He walked around like he owned the place, treating nurses like we were his personal assistants rather than healthcare professionals with decades of combined experience. The way he looked at us, especially the female nurses, made my skin crawl. It wasn't just disrespect. It was active contempt. I remember the first time he really got under my skin. We had a 73-year-old man come in with chest pain. Now, I've seen thousands of cardiac cases, and something about this patient's presentation just didn't sit right with me. His vitals were stable, his EKG looked normal, but there was something in his eyes, the way he was breathing, the slight grayness around his lips that screamed danger to me. I approached Dr. Evans Jr. and said, "Doctor, I think we need to consider this patient might be having a silent MI. His presentation is subtle, but I've seen this before." You know what this arrogant piece of work said to me? He actually rolled his eyes and said, "Let's wait for the labs and imaging to tell us what's wrong, instead of relying on nurse intuition." I don't make medical decisions based on feelings. I stood there, stunned. In 15 years, I had never been dismissed so completely by a resident. But I held my tongue because I'm a professional. 20 minutes later, that patient coded. His troponin levels came back sky high, and he was having a massive heart attack. We got him stabilized into the cath lab, but those 20 minutes of delay could have cost him his life. Did Dr. Evans Jr. apologize? Did he acknowledge that maybe, just maybe, an experienced nurse might know what she's talking about? Of course not. He just moved on to the next patient like nothing happened. But that wasn't the worst of it. Oh no, it got so much worse. Over the next few months, Dr. Evans Jr. made it his personal mission to undermine every nurse in the department. He would countermand our assessments, ignore our recommendations, and worst of all, he would make snide comments about how nurses should stick to taking temperatures and changing bedpans. He called us Dr. Wannabes and suggested that we were jealous of his medical degree. The other residents started picking up on his behavior, and suddenly the entire culture of our ER was becoming toxic. Let me tell you about some of the other incidents that made my blood boil. There was the time a young woman came in with what looked like a simple UTI. I'd seen her type before, college student, probably drinking too much, not taking care of herself. But when I took her history, something felt off. She was vague about her symptoms, kept looking at her boyfriend nervously, and when I helped her change into a gown, I noticed bruising on her ribs that looked like finger marks. I pulled Dr. Evans Jr. aside and said, "Doctor, I think we need to consider domestic violence here. The bruising pattern is concerning, and her behavior suggests she's afraid to speak freely." He looked at me like I was an idiot and said, "She has a UTI, not a psychology degree. Treat the infection and discharge her." I couldn't let it go. During my break, I went back to talk to the patient privately. It took some gentle questioning, but she eventually admitted that her boyfriend had been hitting her. She was scared to leave, didn't know where to go, and was afraid he'd find her if she reported it. I connected her with our social worker, got her information about shelters, and made sure she had a safety plan. When Dr. Evans Jr. found out, he was furious. He told me I was overstepping my bounds and that I should stick to medical care instead of playing therapist. That patient left with resources that potentially saved her life, but all he cared about was that I had contradicted his assessment. Then, there was the elderly man, who came in with what appeared to be pneumonia, standard presentation, cough, fever, shortness of breath. But I noticed that he kept touching his chest in a specific spot. wincing when he moved a certain way. When I listened to his heart, I heard something that made me pause. It wasn't just the pneumonia. There was something else going on. I suggested to Dr. Evans Jr. that we should get an echocardiogram, that maybe this patient had some cardiac involvement. He dismissed me again, saying that I was trying to complicate a simple case. 2 days later, that patient came back in cardiac arrest. The echo showed he had developed pericarditis as a complication of his pneumonia, something that could have been caught and treated if we had listened to the nurse's assessment. If you're watching this, and you work in healthcare, you know exactly what I'm talking about. If you're not in healthcare, but you're enjoying these stories about workplace justice, make sure you subscribe to Hospital Revenge, because we've got stories that will make your blood boil and your heart sing when justice finally gets served. Hit that subscribe button, and let's dive deeper into what happened next. The pattern continued for months. Dr. Evans Jr. would dismiss nursing assessments, ignore our clinical observations, and treat us like we were obstacles to efficient patient care rather than essential members of the healthcare team. He had this way of talking to us that made it clear he thought we were beneath him, that our years of experience meant nothing compared to his medical degree. He would make comments like, "When you go to medical school, then you can make diagnoses," or, "I need medical opinions, not nursing feelings." The other nurses started avoiding him when possible. They would wait for other residents to be available rather than deal with his attitude. But I couldn't avoid him because I was the charge nurse, and part of my job was to coordinate care with the residents. So I bore the brunt of his arrogance, day after day, shift after shift. I started documenting everything. Every dismissed assessment, every ignored recommendation, every snide comment. I wasn't sure what I was going to do with the information, but I knew that someday, somehow, this guy was going to get what was coming to him. I just didn't know it would involve his own mother. The breaking point came on a Tuesday night in late October. It was one of those nights where everything that could go wrong did go wrong. We had a multi-car accident come in, 2 overdoses, and a domestic violence case all within an hour. The department was chaos, and everyone was running on adrenaline and caffeine. Dr. Evans Jr. was in his element, barking orders and treating the nursing staff like we were military recruits rather than medical professionals. I was working triage when the call came in. A woman in her late 60s was being brought in by ambulance with altered mental status and dizziness. Standard stuff, really. Could be anything from a medication interaction to a stroke to simple dehydration. The paramedics gave report over the radio. 68-year-old female, found by husband sitting in her chair, confused and complaining of dizziness. Vitals stable, blood sugar normal, no obvious trauma. ETA 5 minutes. When the paramedics wheeled her in, I saw something that made my blood run cold. Dr. Evans Jr. took one look at the patient and went white as a sheet. He rushed over to the gurney and I heard him whisper, "Mom?" That's right. The patient was his mother, Mrs. Elizabeth Evans, wife of the famous cardiac surgeon and mother of our arrogant resident. And let me tell you, the transformation in Dr. Evans Jr. was immediate and terrifying. All that clinical detachment, all that supposed medical knowledge, went right out the window. He was no longer a doctor. He was a panicked son, and panic makes people do stupid things. Mrs. Evans was conscious but clearly confused. She kept asking where she was and why everything looked so bright. Her speech was slightly slurred, and she seemed unsteady even while lying down. She was well-dressed, obviously well cared for, but there was something in her eyes that spoke of fear and confusion. She kept reaching for her son's hand, asking him to explain what was happening to her. To me, these were classic signs that needed immediate evaluation. But Dr. Evans Jr. was in full panic mode. He started ordering every test imaginable: CBC, comprehensive metabolic panel, cardiac enzymes, toxicology screen, chest x-ray, CT scan of the head, and he was demanding an MRI of the brain stat. He was throwing around orders like confetti, demanding that everyone move faster, get results quicker, make his mother a priority over every other patient in the department. Now let me explain something to those of you who aren't in healthcare. When someone comes in with altered mental status, especially an elderly person, there's a systematic way to approach the evaluation. You start with the basics: vitals, blood glucose, oxygen saturation, and a focused neurological exam. You don't just throw every test at the patient hoping something sticks. But Dr. Evans Jr. was so panicked about his mother that he wasn't thinking like a doctor anymore. The other staff members were looking at each other with concern. They could see that Dr. Evans Jr. was emotionally compromised, but nobody wanted to be the one to suggest that maybe he should step back and let someone else handle his mother's care. Hospital politics are complicated, and challenging a doctor, especially one whose father basically owns half the hospital, is not something people do lightly. I watched him for about 10 minutes, and it became clear that he was paralyzed by fear. He kept pacing around the bed, adjusting monitors, and demanding updates from the lab that hadn't even received the blood samples yet. Meanwhile, his mother was lying there, getting more confused by the minute, and he was too emotionally compromised to actually examine her properly. He was so focused on getting tests ordered that he wasn't actually looking at his patient. That's when I made the decision that would change everything. I walked over to Mrs. Evans' bed and said, "Dr. Evans, while we're waiting for those results, would you mind if I did a quick neurological assessment?" He looked at me with that same condescending expression and said, "She needs imaging, not nursing assessment. Just keep an eye on her vitals and let me know when the lab calls with results." But I couldn't just stand there and watch. See, there's something called the FAST assessment for stroke. Face, arms, speech, time. It's a simple bedside test that can identify stroke symptoms in minutes, not hours. And looking at Mrs. Evans, every instinct I had developed over 15 years was screaming that this woman was having a stroke. The slight droop to her mouth, the way she was favoring her right side, the subtle speech changes that her son was too panicked to notice. So I did what any experienced nurse would do. I ignored the resident's dismissal and approached Mrs. Evans directly. "Hello, Mrs. Evans," I said gently. "I'm Sarah, one of the nurses here. I'm going to do a quick check on you, okay?" She nodded, though I could see the confusion in her eyes. She was trying to be cooperative, but there was clearly something wrong with her neurological function. First, I asked her to smile. When she did, I noticed immediately that the left side of her mouth drooped slightly. It was subtle, but it was there. The kind of thing you'd miss if you weren't looking for it, but unmistakable once you knew what to look for. Then I asked her to raise both arms above her head and hold them there. Her right arm went up normally, but her left arm was noticeably weaker and began to drift downward after just a few seconds. She was trying to hold it up, but the strength just wasn't there. Finally, I asked her to repeat a simple phrase. "The early bird catches the worm." Her speech came out slurred and unclear. What should have been crisp consonants were mushy, and her tongue seemed to be having trouble forming the words properly. "The early bird catches the worm" became "the early bird catches the worm," with the last word barely intelligible. Face drooping, arm weakness, speech difficulty, classic stroke symptoms. And with every second that passed, more of Mrs. Evans' brain cells were dying. They say in neurology that time is brain, and we were losing precious time while Dr. Evans Jr. was demanding his MRI. I knew that if this was indeed a stroke, we had a very limited window to administer thrombolytic therapy. After a certain point, the risk of bleeding outweighs the benefit of clot-busting medication. I turned to face the resident, my heart pounding but my voice steady. "Dr. Evans, your mother is showing signs of an acute stroke. We need to activate the stroke protocol immediately. The FAST assessment is positive for facial drooping, arm weakness, and speech difficulty. We should start the thrombolytic workup now." The look he gave me was pure venom. In front of his colleagues, other residents, and nursing staff, he said the words that would haunt him for the rest of his career. "She's just a nurse. Call neurology and get my mother to MRI stat. I don't need nursing theories when my mother needs real medical care. Just a nurse." After 15 years of saving lives, of being the first to notice changes in patients, of working nights and weekends and holidays to take care of people like his mother, I was just a nurse. The entire trauma bay went quiet. Everyone heard it. Everyone knew what had just happened. The respiratory therapist stopped what she was doing. The other nurses turned to stare. Even the unit secretary looked up from her computer. In that moment, Dr. Evans Jr. had crossed a line that couldn't be uncrossed. If you're feeling as angry as I was in that moment, hit that like button and let me know in the comments what you would have done. because what I did next was either the bravest or the most foolish thing I've ever done in my career. And I want to know if you think I was justified. Here's the thing about being just a nurse that Dr. Evans Jr. never understood. Nurses don't just follow orders blindly. We're patient advocates. We're trained to speak up when we see something wrong, even if it means going against a doctor's orders. And when I looked at Mrs. Evans lying there, getting more confused by the minute while her son demanded tests that would take hours to complete, I knew I had to act. I made a decision that could have cost me my job, my license, and my career. I walked over to the central nursing station and picked up the red phone. In our hospital, the red phone is used for emergencies only. It connects directly to the hospital operator and activates emergency protocols. I took a deep breath and said, "This is Sarah in the ER. I need to activate code stroke for bed 7. We have a positive FAST assessment and need the stroke team stat." The response was immediate. Within minutes, the stroke team was rushing into the trauma bay. The stroke neurologist, Dr. Patricia Chen, came in and immediately began her own assessment. She performed the same FAST test I had done, plus additional neurological checks. She tested Mrs. Evans' reflexes, checked her pupils, and did a more comprehensive neurological examination. After about 5 minutes, she looked up and said, "This patient is having an acute ischemic stroke. We need to get her to CT immediately to rule out hemorrhage, and then we need to start thrombolytics. Who called the stroke alert?" I stepped forward, my heart pounding. "I did, Dr. Chen. I'm Sarah, the nurse assigned to this patient." Dr. Chen nodded approvingly. "Good catch. How long since symptom onset?" "Approximately 45 minutes since the paramedics picked her up. But the family says symptoms started about an hour ago." "Perfect. We're still well within the window for thrombolytics. Let's move." During this entire exchange, Dr. Evans Jr. stood there with his mouth hanging open. The stroke team was moving his mother to CT, preparing medications, and coordinating care, all based on the assessment of the nurse he had just dismissed as irrelevant. Dr. Chen turned to him and said, "Doctor, are you the treating physician for this patient?" I'm her son. I'm a resident here. Then you need to step back and let us do our job. Your nurse made the right call. Time is brain, and we don't have time to wait for MRI when the clinical picture is this clear." They whisked Mrs. Evans away to CT, and then to the stroke unit for thrombolytic therapy. The entire process took less than 30 minutes from the time I activated the stroke code. Dr. Evans Jr. stood in the empty trauma bay, staring at the spot where his mother's bed had been, looking like he'd been hit by a truck. The news of what had happened spread through the hospital like wildfire. Within hours, everyone knew about the resident who had dismissed the nurse's stroke assessment of his own mother. The story got embellished and exaggerated as it passed from person to person. But the core facts remained the same. A nurse had diagnosed a stroke, a resident had dismissed her assessment, and the nurse had gone over his head to save his mother's life. But the real vindication came 2 hours later. Dr. Chen returned to the ER to give us an update. She found Dr. Evans Jr. sitting in the break room, staring at his hands. The rest of the stroke team, several other attendings, and most of the nursing staff had gathered around to hear the news. "I wanted to update everyone on Mrs. Evans' condition," Dr. Chen announced. "The CT confirmed an acute ischemic stroke in the middle cerebral artery territory. We were able to administer thrombolytics within 2 hours of symptom onset, which is excellent. Her neurological function is already improving, and we expect a full recovery." Then she turned to me specifically. "Sarah, I want to thank you for your quick thinking and clinical assessment. Your FAST evaluation was spot on, and your decision to activate the stroke protocol undoubtedly saved this patient from permanent neurological damage. If we had waited for MRI, we would have lost the therapeutic window. You quite literally saved her brain function." The room was silent except for the sound of Dr. Evans Jr.'s world crashing down around him. Here was a senior attending neurologist, praising the clinical judgment of the nurse he had dismissed as just a nurse, while explaining that his approach would have resulted in permanent brain damage for his own mother. But Dr. Chen wasn't finished. She continued, "This is exactly why we have stroke protocols and why we rely on experienced nursing staff to identify symptoms early. No diagnostic test is more important than a good clinical assessment, and no machine can replace the expertise of a skilled healthcare professional, regardless of their job title." Dr. Evans Jr. looked up at me, and for the first time since I'd known him, I saw something other than arrogance in his eyes. I saw humility, shame, and maybe even a little gratitude. He opened his mouth as if to say something, then closed it again. What could he possibly say? That he was sorry for dismissing my clinical judgment? That he was grateful I had ignored his orders and probably saved his mother's life? That maybe, just maybe, nurses aren't just nurses after all? The beauty of this moment wasn't just that I had been vindicated. It was that everyone in the department witnessed it. Word spread quickly through the hospital about the resident who had dismissed the nurse's stroke assessment of his own mother, and how that same nurse had saved the day by going against his orders. The story became legend in our hospital, and Dr. Evans Jr. became the cautionary tale about the dangers of arrogance in medicine. From that day forward, something changed in our ER. Dr. Evans Jr. never again dismissed a nurse's clinical assessment. In fact, he became one of the most collaborative residents in the department, always asking for nursing input and treating us as the medical professionals we are. He would often say to new residents, "Always listen to your nurses. They see things we miss, and they can save you from making career-ending mistakes." Mrs. Evans made a full recovery, by the way. She returned to the ER about a month later to thank the staff who had taken care of her. When she saw me, she grabbed my hands and said, "You're the nurse who saved my life, aren't you? My son told me everything. He said you went against his orders because you knew what was best for me." Then she did something that brought tears to my eyes. She turned to her son and said, "Marcus, you need to listen to nurses like Sarah. They know what they're doing." But the story doesn't end there. The ripple effects of that night continued for months, and the transformation of Dr. Evans Jr. became one of the most dramatic personality changes I've ever witnessed in my career. The hospital administration used our case as a teaching example in grand rounds, bringing in speakers to talk about the importance of interprofessional collaboration and the dangers of hierarchical thinking in healthcare. Dr. Evans Jr. actually volunteered to speak at these sessions, sharing his experience and encouraging other residents to value nursing expertise. I remember one particular Grand Rounds presentation where Dr. Evans Jr. stood in front of over 200 healthcare professionals and said, "6 months ago, I almost cost my mother her life because I was too arrogant to listen to an experienced nurse. I dismissed 15 years of clinical expertise because I thought my medical degree made me superior. I was wrong, and I'm grateful that Sarah had the courage to go against my orders and save my mother's brain function." The audience was stunned. Here was a resident, publicly admitting his mistakes and crediting a nurse with saving his mother's life. It was unprecedented, and it sent shockwaves through the hospital's traditional hierarchy. Suddenly, other residents started asking nurses for input. Attending physicians began including nursing assessments in their decision-making, and the entire culture of our hospital began to shift. But perhaps the most satisfying part of this whole story is what happened to Dr. Evans Jr.'s reputation among his peers. Before that night, he was known as the Golden Boy, the son of the famous surgeon who was destined for greatness. After that night, he became known as the resident whose mother's life was saved by a nurse he had dismissed. The irony was not lost on anyone in the hospital, and it became a cautionary tale that was whispered in break rooms and shared during shift changes. I've been asked many times if I felt bad for embarrassing Dr. Evans Jr. in front of his colleagues. The answer is no. I don't feel bad at all. Sometimes people need to be humbled in a very public way to learn important lessons. His arrogance could have cost patients their lives, and it took his own mother nearly becoming a victim of his attitude for him to understand the consequences of his behavior. The truth is, healthcare is a team sport. Doctors, nurses, technicians, therapists, and support staff all play crucial roles in patient care. When one member of the team dismisses another based on job title rather than expertise, patients suffer. What happened that night was a perfect example of why mutual respect and collaboration are essential in healthcare. In the weeks following the incident, I noticed other changes in the department. Nurses who had previously been afraid to speak up started voicing their concerns more confidently. Residents began asking for nursing input before making decisions. The entire atmosphere became more collaborative and less hierarchical. It was as if that one night had broken down barriers that had existed for years. Dr. Evans Jr. also made personal changes that surprised everyone. He started arriving early to his shifts to talk with the night nurses about what they had observed during their shifts. He would ask specific questions about patient assessments, medication responses, and family dynamics. He began to understand that nurses spend more time with patients than doctors do, and that our observations are invaluable for making accurate diagnoses and treatment plans. I remember one particularly busy night, about 2 months after the incident. We had a young man come in with what appeared to be a simple drug overdose. He was unconscious, had track marks on his arms, and his friends said he had been using heroin. It seemed like a straightforward case, but something about the patient's breathing pattern caught my attention. It wasn't quite right for a typical opioid overdose. Dr. Evans Jr. was the attending resident, and instead of dismissing my observation, he asked me to explain what I was seeing. I told him that while the patient had clearly been using drugs, his respiratory pattern suggested there might be something else going on. We did additional tests and discovered that he had also taken a large amount of acetaminophen, which can cause liver failure if not treated quickly. Because we caught it early, we were able to administer the antidote and prevent permanent liver damage. After we stabilized the patient, Dr. Evans Jr. pulled me aside and said, "Sarah, if this had happened 6 months ago, I would have dismissed your observation and focused only on the obvious overdose. That patient could have died from liver failure because I was too arrogant to listen to you. Thank you for teaching me to be a better doctor." That moment encapsulated everything that had changed. Dr. Evans Jr. had learned that being a good doctor wasn't about being the smartest person in the room or having the most advanced degree. It was about being humble enough to listen to everyone on the team and using all available information to make the best decisions for patients. The story of that night also had an impact on my own career. Word of what had happened spread beyond our hospital, and I was invited to speak at nursing conferences about the importance of clinical assessment and patient advocacy. I became something of a minor celebrity in nursing circles, known as the nurse who saved a doctor's mother by going against his orders. But more importantly, the incident gave me a platform to advocate for nursing expertise and the importance of interprofessional collaboration. I've spoken at dozens of hospitals, sharing the story and encouraging nurses to trust their clinical judgment and speak up when they see something wrong. The response has been overwhelming, with nurses from all over the country sharing their own stories of being dismissed by arrogant physicians. One of the most powerful responses came from a nurse in Texas who wrote to me after hearing my presentation. She said that my story had given her the courage to challenge a physician's orders when she noticed signs of sepsis in a patient. The doctor had dismissed her concerns, but she persisted and eventually convinced him to order blood cultures. The patient was indeed septic, and the early treatment saved his life. She said that if she hadn't heard my story, she might have stayed quiet and let the patient deteriorate. That's when I realized that the impact of that night went far beyond my personal satisfaction or Dr. Evans Jr.'s education. It was about changing the culture of healthcare and empowering nurses to use their expertise to save lives. Every time a nurse speaks up because they heard my story, every time a doctor listens to nursing input because they remember what happened to Dr. Evans Jr., lives are potentially saved. Looking back on that experience, I realize it was more than just professional revenge. It was a teaching moment, a wake-up call, and a reminder that in healthcare, ego has no place at the bedside. The only thing that matters is what's best for the patient, and sometimes that means just a nurse knows more than the doctor with the fancy degree. The relationship between Dr. Evans Jr. and me also evolved in unexpected ways. What started as mutual antagonism became mutual respect, and eventually something resembling friendship. He would often seek my input on difficult cases, and I began to see him as a colleague rather than an adversary. It was a transformation that neither of us could have predicted, but it demonstrated the power of humility and the importance of learning from our mistakes. I still work in the same ER, and I still encounter arrogant residents from time to time. But now I have a story to tell them. I tell them about the night a resident dismissed my stroke assessment of his own mother, and how that dismissal almost cost her the use of her brain. I tell them about the importance of listening to experienced nurses, of valuing clinical expertise over hierarchy, and of remembering that in healthcare, we're all working toward the same goal: saving lives. The story has become part of the hospital's folklore, passed down from resident to resident, nurse to nurse. New staff members are told about the night Sarah diagnosed the stroke, and it serves as a reminder that respect and collaboration are essential for providing the best patient care. Dr. Evans Jr. finished his residency and went on to become an attending physician in emergency medicine. He's actually a good doctor now, one who values nursing input and treats everyone with respect. Sometimes I wonder if he remembers that night as clearly as I do, if he still thinks about how close he came to losing his mother because of his arrogance. But I don't dwell on the past. I'm too busy training the next generation of nurses, teaching them to trust their instincts, to speak up when they see something wrong, and to never let anyone dismiss them as just a nurse. Because we're not just nurses. We're patient advocates, lifesavers, and sometimes we're the only thing standing between a patient and a medical mistake. The incident also led to policy changes at our hospital. The administration implemented new protocols for stroke assessment that specifically included nursing input in the decision-making process. They also created a formal mechanism for nurses to escalate concerns when they feel their clinical assessments are being dismissed inappropriately. These changes weren't just symbolic, they had real impact on patient outcomes. In the year following the implementation of these protocols, our hospital's stroke response times improved significantly, and patient outcomes in stroke cases showed marked improvement. The administration credited much of this improvement to the enhanced role of nursing assessment in the stroke protocol. I've also used this experience to mentor other nurses facing similar challenges. I've had countless conversations with nurses who were afraid to speak up, who doubted their own clinical judgment, or who were intimidated by arrogant physicians. I tell them my story, and I remind them that their experience and expertise are valuable, regardless of what anyone else might say. One young nurse in particular comes to mind. She was fresh out of nursing school, working her first job in our ER. She was intelligent and capable, but she lacked confidence when dealing with physicians. I took her under my wing and shared my experiences, including the night with Dr. Evans Jr. and his mother. Over time, she developed the confidence to speak up when she noticed something important, and she's now one of our most respected nurses. The moral of this story isn't just about getting revenge on an arrogant resident. It's about the importance of experience, the value of clinical intuition, and the power of speaking up for what's right, even when it's difficult. In healthcare, every voice matters, every observation counts, and every professional deserves respect, regardless of their job title. If you enjoyed this story of professional justice and want to hear more tales from the hospital front lines, make sure you like this video, share it with your friends, and subscribe to Hospital Revenge for more stories that will restore your faith in workplace karma. And let me know in the comments, have you ever had to stand up to someone who underestimated your expertise? What happened? I read every comment, and your stories inspire me to keep sharing these tales of justice served. Remember, in healthcare and in life, never underestimate the power of experience, the importance of advocacy, and the satisfaction of being right when everyone else is wrong. Sometimes the best revenge is simply being excellent at your job when others doubt your abilities. And sometimes, just sometimes, that excellence saves lives and teaches unforgettable lessons about respect, humility, and the true meaning of patient care.